Good evening all. We are proud to introduce XP Connect, a webinar series initiated by GE Healthcare Ultrasound, and this is a regular series every fortnight featuring the best experts in the field of ultrasound. So after 4 successful sessions, I welcome you all for the 5th session of GE XP Connect powered by Volizon. Today's session is by Dr. Bijoy Balakrishna on evaluation of fetal thorax. Dr. Bijoy is a specialist lead consultant fetal medicine unit, SIMAR, Cochin, since 2007. SIMAR has been recognized by the National Board to impart fellowship in high-risk pregnancy and perinatology, the third such institute in India and first in Kerala. Dr. Bijoy has attended over 70 plus national and international conferences and has more than 15 publications under his name. He is also the winner of Kamal Bakshi Award for Best Paper in Asia Pacific Fetal Maternal Congress 2017. And the session will be for 45 minutes followed by 10 to 15 minutes of question and answers. You can send in your questions anytime by using Ask Questions box underneath the video screen, and Dr. Bijoy will answer them post his session. So further without ado, let me welcome Dr. Bijoy to begin his session. Over to you, Doctor.
Good evening, everyone. I must say this is new for me as well, because I always connect to the audience when I'm on stage and speaking. So this experience is kind of new where I cannot see you out there. But this has its obvious advantage, and the obvious advantage is that if you find this talk boring and if you're yawning and sleeping, I will not know, and I'll assume that you like this presentation. And the other obvious advantage is that I can sit here in my pajamas and talk to you while I sip on a glass of beer. Well, jokes apart, we're talking about the fetal thorax. And for me, the fetal thorax is like a cage and it has two prisoners. Something like our modern day marriages. Two distinct people put in a cage and they're asked to live together for the rest of their lives. And the heart has been covered beautifully by my colleague Dr. Balu last week. And I'm going to talk about the less glamorous prisoner in this cage, lungs. And if you think about the anomaly scan, it is obvious that we spend a lot of time on the heart. We have got the systematic analysis of the heart, but we forget about the lungs. It's just the background and we don't pay much attention to it. And probably because it's a very homogeneous structure, slightly more echogenic than the liver. But I want you to look at two important things while you look at the thorax, and especially at the lungs. And when you look at the lungs, two things stand out as the gestational age progresses. And the first and most important thing is the echogenicity of the lungs. If you can see on the left-hand side of your screen, you're seeing an earlier pregnancy. The lungs are not that echogenic, and as you progress down the gestational age, it becomes slightly more echogenic. And when you see these echogenic lungs, it's obvious for you, at least for beginners, to think that there is something wrong with the lungs, but it is not. It is a natural progression. Another point that I want all of you to look at is to look at those ribs. The ribs have to always cross the crux of the heart, and that is when you know that the ribs are of the normal size and they are not short. I don't have a lot of time to cover the ribs and all the pathologies that you can see in the thorax. I'm going to confine myself to the lungs. And while talking about the lungs, I'm going to talk about two specific groups of pathologies: intrinsic to the lungs and extrinsic to the lungs. Intrinsic being CPAMs, BPS and chaos, and extrinsic when you have an intruder that comes into this holy marriage, that is the congenital diaphragmatic hernia. So when we talk about diaphragmatic hernia, it is obvious that there is a discontinuity in the diaphragm and you have herniation of abdominal viscera into the thorax, but that particularly is not the problem. The problem is with the lungs. The lungs become hypoplastic and you have a problem called as pulmonary hypertension. Now this happens because you have this herniation occurring between the 3rd to 16th week of lung development, and so there is not only a decrease in the lung mass or lung size, there is an overmuscularization of the pulmonary vasculature leading to pulmonary artery hypertension later on. There are a number of causes which cause this failure to closure of the diaphragm. It could be genetic or environmental factors being vitamin A deficiencies or maybe external drugs that these mothers are using. But from a genetic point of view, we are worried about recurrence risks. So aneuploidies, translocations, autosomal recessive disorders are what we are worried about. Which means that whenever you have a congenital diaphragmatic hernia, it is imperative that you have to follow them up and look for aneuploidies. When you look at the different types of diaphragmatic hernias that are possible, it could be bilateral, it could be right-sided, or it could be most likely left-sided. And within left-sided hernias, you have different locations, the most common one being the posterior lateral in location. It could be central, it could also be anterior and retrosternal, but most likely when you see a left-sided hernia, you're always dealing with one of these three conditions. It could be with the stomach up, it could be with the stomach down, it could be along with the liver or with the liver down. And it is very important for us to make that distinction. When the stomach is up, it is a very straightforward diagnosis. You see a cystic structure within the thorax and you're not able to identify the stomach within the abdomen, and naturally your diagnosis would move towards a congenital diaphragmatic hernia with stomach up. And this is an obvious diagnosis that can be even picked up at 12 weeks. Now, having said that, it is obvious only if the stomach goes up into the thorax. So when you see that the stomach is in the thorax, and you have to check for the stomach whether it is present in the abdomen, and also at 12 weeks, when you take a cross-sectional view of the fetus, it is clear that you can see the stomach pushing the heart to the opposite side. So stomach up is not a major problem, but when you have the stomach down and you're seeing an echogenic mass that is pushing the heart to the opposite side, then that is when you're worried whether you're dealing with a diaphragmatic hernia or whether you're dealing with any of the other masses. I just want you to see this part, which probably you missed, where you can see the thorax in two different gestational ages, one at the early gestation and one at a later gestation. The point being to show you the increase in echogenicity as the gestational age progresses, and that is very important, understanding that increase in echogenicity is actually a normal physiological phenomena and not that there is something wrong with the lungs. And another point is to look at the ribs and see that it crosses the crux of the heart. And as I told you, we're going to talk about only basic lung pathologies, intrinsic and extrinsic pathologies, CPAMs, BPS, chaos, and the congenital diaphragmatic hernia. As I told you before, already I've covered this on what diaphragmatic hernia of the pathology is and what is the critical period of lung development, so I'm not going to spend much time on that. But let's go to the diagnosis part straight away. So when you have the stomach up in the thorax, it is a pretty straightforward diagnosis. You can pick it up even at 12 weeks. And if you look at your 12-week scan and if you see the cystic structure up within the thorax and pushing the heart, and obviously you won't see the stomach in the abdomen, and it is easy to pick it up, especially at your 12-week scan. But the problem comes when you have the stomach down and you have the heart pushed to one side and you're not sure whether you're dealing with a diaphragmatic hernia or not. And this is possible when only the bowel is herniating up into the thorax. So the stomach is pushed down to a lower level, and the differential here is again other lung pathologies which cause the lung to be echogenic, like CPAM and BPS. So 2 points you can look for here. One is the elongation of the stomach. Here you have the diaphragmatic hernia and you have bowel pushing up into the thorax and pushing the stomach downwards. And when that happens, you will see that the stomach takes a tubular sort of a shape and is almost reaching down into the pelvis. And in this particular case, when we looked at it closer, we could see that within the thorax, you could see the small loops of bowel being present there. This is another case again similar to the one that I showed before. You can see that the heart is being pushed to one side. There is echogenicity on the contralateral side. No stomach bubble is seen, and you're worried whether you're looking at an echogenic mass of the lung or not. But then when you look closely at the stomach, you can see that the stomach is elongated. It is sort of pulled downwards, and it's lying so close to the bladder that tells you that something is pushing the stomach downwards. And that is where you will start thinking about probably a diaphragmatic hernia rather than an echogenic lung mass. The other clue would be the superior mesenteric artery. The superior mesenteric artery supplies the upper part of your small bowel, and you can see that it exits out of the descending aorta just distal to the celiac trunk. So if the bowel is herniating upwards, this vessel has to follow as well. So that is an indirect evidence that tells you that probably you're looking at the small bowel that is herniating up into the thorax. Now here is a condition where the stomach is down, and you can see clearly that the superior mesenteric artery is going upwards, crossing the diaphragm and supplying some echogenic structure there, which has a connection into the abdomen, clearly telling you that it is the small bowel that is up, and what you're dealing with is a diaphragmatic hernia. And one of the best ways to practice looking at the superior mesenteric artery is to look for the superior mesenteric artery in a full-blown congenital diaphragmatic hernia where the stomach is up, and there when you look at this vessel you can clearly see that along with the small bowel the superior mesenteric artery is also going up, and thereby giving you enough evidence to tell you that the small bowel is up. So the more you look at it, the more you will be able to identify it in conditions where the stomach is below the diaphragm. The next big question is whether the liver is up or down. One important clue that you can use is to look at the position of the stomach in relation to the crux of the heart. So if you find that the stomach is at the level of the crux or below, then it means that there is a possibility of the liver being up. The other obvious evidence is to look for the hepatic vessels or even the gallbladder within the thorax. Because if these things are present, it's obvious that definitely the liver is up. But another clue that you can use is the deviation of the umbilical vein, and that is especially useful if you're looking at right-sided diaphragmatic hernias. Now normally what happens to the umbilical vein is that it sort of courses like this. It enters into the abdomen and courses away from the stomach towards the right. But when you have a diaphragmatic hernia, look at how the umbilical vein changes its course and sort of straightens out and moves slightly upwards, creating that deviation. So when you see this sort of a deviation, especially when you're looking at right-sided diaphragmatic hernias, this sort of clue is very, very essential in making that diagnosis. And also when you see the hepatic vessels, it becomes sort of a straight, clear-cut diagnosis. You can see the hepatic vessels that are entering, they are going above the diaphragm, and clearly you know that the liver is up. But once you see the diaphragmatic hernia, it's again very important to look at other systems. Because diaphragmatic hernia is one of those disorders where there is a strong genetic component involved. And the most common pathology that you should be looking for is congenital heart disease. And when I'm talking about congenital heart disease, it is not just for the fetus. You have to take a family history and find out if there has been congenital heart disease within the family as well. Because there is a close connection between congenital heart diseases and diaphragmatic hernias, which makes amniocentesis and genetic evaluation very, very necessary. And this is a simple example where this patient came to us very late. There was a diaphragmatic hernia. They were counseled based on their lung head ratios and things like that. But somebody forgot to look at the eyes, and this patient was having an ophthalmia. So it's very, very important to understand that there is a huge association between congenital diaphragmatic hernia and other malformations. Now, having said that, there are certain associations that you should not be worried about. And one particular association is this: cardiac compression because of the mass. Now, when you have a mass that is compressing the heart, you're going to get LV-RV disproportion because of that compression. And in diaphragmatic hernia, you can get functional aortic stenosis. Now, as you can see very clearly here, there is a mismatch between the LV and the RV, and if you look closely, it is creating a sort of a compression and creating functional aortic stenosis in this particular fetus. But here the outcomes, there are probably a lot of controversy on this, but here the outcomes are good because this aortic stenosis is not going to have any long-term outcomes on this fetus. So what are the factors that are going to affect this fetus? Because when you're talking about diaphragmatic hernia, we know it is not the hernia that we're worried about the lungs. And this paper by Jan de Press group is pretty useful in trying to address these issues. Traditionally, we were looking at these factors. We're looking at gestational age diagnosis, degree of mediastinal shift, polyhydramnios, lung size, and to see if the stomach was within the thorax. But none of this works, and what we use nowadays is the LHR and to look for liver herniation. Now in LHR, we look at the contralateral lung, and we find out the size of the lung and then compare it with the head circumference and get a ratio. Now this can be done either by your AP or transverse dimensions that you take as you've seen in this image, or you can take a line trace method. The line trace method is supposed to be better, but it depends upon what you're more comfortable with, and I think both of them should be working fine. Now with the lung HR ratio or LHR ratio, if you find that it is high, it is greater than 1.4, it means that the lung on the opposite side is pretty good and therefore the outcomes are good. If it is less than 1, the outcomes are bad and survival is less. And if it is between 1 and 1.4, you will need to put this child on ECMO. Now this was what was being used before. Now the problem with LHR is we have the head circumference that acts as a surrogate for the gestational age. Now that's good. It is a good surrogate. We know that we use head circumference as a surrogate for the gestational age in a number of factors. But the problem here is that the lung and the head size are growing at different rates. If you look at the time interval between 12 and 32 weeks, the head circumference increases only 4-fold, but the lung increases by 18-fold. So that means you have two different things growing at two different velocities, and therefore it will not actually be an accurate marker, and it is not useful in right-sided diaphragmatic hernias. So as a way out of that, you have to use what is known as an observed or expected LHR. And it can be used in right-sided diaphragmatic hernias as well. So what you're doing here is you're having an observed LHR, an LHR that you are seeing on this patient, and the expected LHR for that particular gestational age. So when it is less than 15%, you know that this child has very little chance of survival. But when it is 15 to 25, 26 to 45, survival keeps on increasing, and when it goes beyond 45, the survival is almost greater than 90%. Now before you using O by E LHR, you have to look at the numbers on the left side of your screen. It is important that you make this assessment between 22 and 28 weeks. Let me explain why. If you do this at 19 weeks, and if at 19 weeks you find that the O by E LHR is less than 15%, you can be very sure that probably this child will not survive. But if you have an O by E LHR of greater than 45% at 20 weeks, there is no way you can say that it is going to remain like that till 26 weeks. You know that congenital diaphragmatic hernia is a progressive disorder, and therefore if you do not watch this baby later on, it is very much possible that this greater than 45% O by E LHR can become less than 15% at 25 or 26 weeks. And therefore the best time to do an O by E LHR and prognosticate a congenital diaphragmatic hernia based on that would be between 24 and 26 weeks. And in India that is going to be a problem because we know that our termination window closes at around 20 weeks, and therefore we have to be very careful when we prognosticate these fetuses, especially when they have a good LHR before 20 weeks. And obviously the second thing that works in this in favor or against this prognosis is to look at the liver. And if the liver is up, naturally the prognosis is going to be bad. There are new indicators that are being used like MRI, 3D volumes, gradation of the liver herniation and things like that. But in routine clinical practice, you have to rely on O by E LHR. Another thing that's coming up is to look for the signs of pulmonary artery hypertension by looking at what is known as the Magoon index. And it is supposed to be lower in abnormal cases, but still the jury is out on this, on whether we can use this on a regular basis or not. So largely, to sum up, in diaphragmatic hernia, you have to depend upon O by E LHR. So once you know that you have the O by E LHR, you have three options available in front of you. With a patient with diaphragmatic hernia, it could be either termination of pregnancy, conservative management till term, or you can go in for fetal. When you have an LHR of less than 15%, it is obvious that termination would be an option there. And greater than 45%, all of them will survive, so you have to go for a conservative management till term. But the group in between, that is 15 to 45%, is the group where fetal is probably going to be useful. And fetal is basically a tracheal occlusion. You're putting in a balloon to occlude the trachea around 27-28 weeks and allowing the lungs to overinflate. It is creating an artificial obstruction of the upper airways and causing the lungs to inflate and thereby allowing them to proliferate. Now this is being done as a part of a trial. This is also total trial EDU, and anyone who is interested can look up into it, and I think it's not being currently done in India as yet. So the balloon, what it basically does is it goes into the trachea, causes a dilatation of the trachea and the lungs, causing overinflation of the lungs and thereby creating an artificial chaos actually, and allowing the lungs to expand and be more mature. Now that was about the diaphragmatic hernia. Moving on, we look to intrinsic pathologies, and let's start off with congenital pulmonary adenamatoid malformation. This is by far the most commonest lung pathology that you can get. 59% of all your prenatal lung lesions are going to be CPAMs. And here there is an imbalance between proliferation and apoptosis. So the lung continues to grow unchecked, leading to a proliferative lung mass which is connected to the tracheobronchial tree. And here this connection is particularly important. There are three types of abnormal CPAMs that you can get. One would be the microcystic variety, where you have cysts less than 5 mm, which is the most common. The second most commonest one being a mix of microcystic and macrocystic variants. And the third one would be the macrocystic type, where you have cysts that are larger than 5 mm. So this is how a macrocystic CPAM would look like: a huge cyst within the thorax, pushing the heart to the opposite side. And this is how a microcystic CPAM would look like, definitely more echogenic and creating a mediastinal shift across. But the crux in the diagnosis of CPAM is not the mass or the echogenicity, but the vascular supply. It is supplied by the pulmonary vasculature. Both the artery and the vein comes from the pulmonary vessel, and thereby that is what clinches the diagnosis in favor of a CPAM. So you would have an echogenic or cystic mass depending upon the type. It could be either on either lung side, it could be on the lower or in the upper lobe, but usually on the lower lobe. And the significant point here is the mediastinal shift that you would be seeing. So naturally what happens is that these CPAMs grow to a maximum speed between 20 and 26 weeks. They peak at around 25 weeks, and after that they plateau downwards. Now there are two ways this CPAM can take in their natural history. One is they can completely resolve by around 50% of the time, and sometimes the other 50% can develop hydrops. Not all of them, but some of them can develop hydrops. But the intriguing question in CPAM is, are they actually resolving? The resolving ones are usually the microcystic types, and there is this argument that they are not actually resolving. What is happening is that the thoracic size is increasing in relation to that mass, and secondly, two things happen. The CPAM echogenicity decreases and the echogenicity of the surrounding lung increases. If you remember what I told you at the beginning of my lecture, the lung echogenicity keeps on increasing as the gestational age progresses. So if you look at this particular case, you can see that these are the two same pictures of the same patient, and on the left side at a lesser gestational age, it is obvious that you can see an echogenic lung mass, but later on what happens here is that it has completely disappeared. And this makes us wonder whether actually this is actually resolving, or is it because of the surrounding lung tissue becoming more echogenic. And therefore, in these conditions, you're going to rely on the mediastinal shift. And you can see that the mediastinal shift is definitely much less compared to what you saw in the earlier trimester. And that should be kept in mind when you find that it is difficult to discern the CPAM in later gestations. But the theory in favor of resolution is that these masses actually outgrow their blood supply, or sometimes they can undergo spontaneous torsion, and that is probably the reason why they resolve. And resolution usually occurs in the microcystic types with low CVR rather than the macrocystic ones. The risk of hydrops is real in CPAM, and is much more than other lung pathologies. And it is related to the gestational age, obviously, because we know that the maximum velocity of growth is between 20 and 26 weeks. And therefore, if you have a CPAM that is sufficiently big at an earlier gestational age, you're going to be worried about it. The size of the mass definitely going to cause compression of the IVC and can cause can cause high drops because of the mediastinal shift, and it is not at all related to the type. So it does not matter if it is microcystic or macrocystic. The risk depends upon the gestational age and the size of the mass. And the sad part here is that when you have high drops, the mortality rate approaches to close to 100%. So how can we predict that? There are a number of things that we can look at: the CVR, the MTR, or the mass to thoracic ratio, and also to a certain extent LHR. But by far the best method would be CVR, which is CPAM volume ratio, where you take the measurement of the height, the anterior posterior diameter, the transverse diameter of the lung mass, and then compare it with the head circumference to get the ratio, the CVR ratio. Now, two numbers you have to remember here, 1.6 and 0.9. When it is greater than 1.6, there is a risk for high drops, and when it's less than 0.9, there is a good chance that this child will have a good outcome. But an important thing that we always forget is that CVR works absolutely well for microcystic CPAMs, and it is not so useful if you have a large dominant cyst. So if you have a large dominant cyst within a CPAM, and if you find that the CVR is less, there is a possibility that there could be bleeding or sudden effusion into that cyst, and suddenly the size can increase and you can have acute high drops. So yes, you have to look at the CVR, and you have to be careful when you're looking at CVR in macrocystic variants. And after that comes the question on how frequently you will follow up. You can follow them up on a weekly basis or on a monthly basis. And here again, two things are very important: CVR and gestational age. So if you have a higher CVR at an earlier gestational age, it tells you that there is potential for more growth, and therefore you would be following up these fetuses more closely and following them up on a weekly basis. But if the CVR is low and you're picking them up later on at maybe 30 weeks, you know that this CVR, this CPAM, has already passed its peak velocity of growth, and therefore now this CPAM is not going to grow any more further, and therefore you need to call them up only on a monthly basis. So the difference is between how big the CVR is and how early you make the diagnosis on deciding whether you want to go in for a weekly follow-up or a monthly follow-up. Now, coming to interventions, by far CPAMs are the ones that you can intervene and create a difference. And of all these interventions, steroids and thoracoamniotic shunt are probably the most important interventions that you can think about. Thoracocentesis, the problem is that even if you take out the fluid within those cysts, there is a possibility that it will rapidly reaccumulate and you will be back to ground zero. And resection of the mass is slightly more difficult because you have to do a laparotomy to get this baby out and resect the mass. Steroids, they work especially for microcystic CPAMs. You give it at the same dose as you give for lung maturity, 12 milligrams, 24 hours apart. Normally, we don't give it for maximum of more than 2 courses, but you can even give it for 3 to 4 courses, as some papers are saying. But here the problem is, again, is steroids actually working, or are we looking at the natural history of CPAMs? That is still out. Nobody knows for sure whether steroids actually works or not. The story behind this is that when there was a large CPAM, a group of investigators decided to give steroids and deliver the baby out and then try to save the baby ex utero. But when they gave steroids and they followed up this patient by doing a scan within 24 hours, they found out that the CPAM was resolving. And that is when it came, there came this confusion as to whether steroids were actually working or whether it was actually the resolution of the CPAM. But by far the most exciting treatment modality would be thoracoamniotic shunting. This works for macrocystic lesions where you have a large dominant cyst and it is never done before 20 weeks because of chance of damage to the fetal thorax. Now, macrocystic CPAMs can have a number of cysts, but all these cysts communicate with each other. So when you're doing thoracoamniotic shunting, it is only required that you put the shunt in one cyst, and from there you can drain out all the other cysts. And so the shunt that we use is the Harrison shunt. There is also the Roddick shunt, which is a slightly more cumbersome counterpart than this sleek looking shunt, and this is what we prefer, which has got a needle that is here you can see with the stellate inside, and this is the shunt that we use. This is a pigtail, double pigtail catheter, and you can see that there are multiple coils on one end and there is a single coil on the other side. And this was the first case that we did in 2012, and you can see that there is a huge dominant cyst here. Severe does not matter here, because when you have such a large cyst, it is imperative that most of these conditions could go into high drops. So here what we do is we anesthetize the fetus giving pancuronium, and we then put in the Harrison's needle into the cyst, take out the needle, and then insert the pigtail catheter into that cyst. If you watch closely, you can see the catheter coming out slowly into the cystic mass like a coiled tube as it comes out. Now when this happens, you would get some amount of pleural effusion, which is okay and will resolve on its own. But this was our first case, and being our first case, we were also naive a bit. We thought we could do good by putting a shunt in, but that did not work out very well, because the shunt went in beautifully and it drained the cyst beautifully. But the problem was that the fetus had other plans here. And here you can see the shunt coming out slowly from the tip of the needle, and there you can see the double coil there. And as slowly we withdraw the needle outwards, there is an amount of pleural effusion that is coming here because of the leakage from the cyst. There you can see that effusion there. It's very close to the heart, but yeah, that is one of the problems of going in anteriorly. And there you can see the coil coming out on the anterior thorax, and then you can see drainage of the cyst into the external amniotic cavity. Now the problem here is that we placed it anteriorly, and so when we place a cyst anteriorly, babies will be babies, and they pulled it out, pull out this cyst, and this baby pulled out this cyst, pulled out this tube pigtail catheter after a week, and after that we had to actually try to do this thing again. But we learned from our mistakes, and then this we did last year, and we decided that it's best to go posteriorly, and that is the recommended method world over. You go posteriorly on the posterior aspect of the thorax, behind the baby, below the scapula, and you enter the cyst and place the catheter on the back of the fetus. And that way the baby cannot pull it out, and this child had an excellent outcome. And in this case again, you had a macrocystic CPAM with signs of developing high drops. Now coming to the next entity, bronchopulmonary sequestration. Now bronchopulmonary sequestration, or BPS, is different from CPAM in that you have a non-functioning lung mass. There is no communication with the tracheobronchial tree, and the differentiating point is the blood supply. The systemic supply is what differentiates a BPS from CPAM, and most often it occurs on the left side. 80% of the time it is going to occur on the left side. There are two types of BPS that you should know about: the intralobar and the extralobar type. The intralobar occurs within the normal lung. It is covered by the visceral pleura, and it always drains into the pulmonary vein. The extralobar variety is outside the normal lung, has its own visceral pleura, and drains into systemic veins, but sometimes can drain into the pulmonary veins as well. Now the common misconception we have is that extralobar means outside the thorax. It does not mean that. It means outside the normal lung. So it can be within the thorax as well. And the meaning of extralobar is that the covering is its own independent covering and not the covering that comes from the lungs. And when it is below the diaphragm, it could be above the kidneys, especially on the left side, where you could have differentials like neuroblastoma, and it's usually more common on the left side. So when it is present in the thorax, you see for a triangular echogenic mass with the base resting on the diaphragm, and it is more echogenic than your surrounding lung tissue. The natural history of BPS is much better than that of a CPAM. In fact, 75% of them will decrease in size, and the high drops that is possible with BPS is extremely rare. So BPS is actually a much better diagnosis than CPAM. Now, high drops here can occur not only because of the mass effect, but also because of an AV shunt that can occur in these large masses and can cause cardiac failure because of the AV shunt itself. Now, while talking about the mass effect, there is one point that I want all of you to understand. If you have a mass within the thorax with hydrothorax, it is almost always an extralobar thoracic bronchopulmonary sequestration. It can't be anything else. It's like a spotter. If you have an echogenic lung mass, as you see here, with pleural effusion, then most likely you're dealing with BPS. As you can see here very clearly, there is pleural effusion. You have a mass that is sitting, and it's usually extralobar because it is outside the lung parenchyma, has its own visceral covering which is irritating the pleura and the diaphragm and creating that sort of an effusion around the lungs. So when you see this picture, you don't have to think anything else. You're looking at a bronchopulmonary sequestration. So here again, you know that size is important because size is what is going to create hydrops later on. So you have CVR, you can use CVR, but it is not as predictive as CPAM, as in CPAM. So you probably can use CVR as an adjunct, but you cannot decide on any intervention based on CVR size alone unless hydrops develops. So the differentials, the two common differentials that are there for the infradiaphragmatic BPS is a neuroblastoma and adrenal hemorrhage. Neuroblastomas are usually on the right side, they can be cystic, and the difference between BPS is that they grow with their gestational age. But what happens with BPS is that they decrease in size, and it's usually a third trimester diagnosis. Adrenal hemorrhage, the most important point being that they change appearance over time. It can be echogenic first, then it becomes hypoechoic, and then finally it becomes cystic. And you can also have calcification within that area, and it is also a third trimester diagnosis. So here you have a large cystic mass which was initially echogenic and then turned out to be hypoechoic, and that's how you know that you're dealing with a hemorrhage. Intervention very rarely required because most of these do well. But when you have a mixed lesion meaning when you have both BPS and CPAP, and in those cases probably steroids and shunts would help, but otherwise none of these things work in bronchopulmonary sequestration. And the only thing that can be helpful is if you have an extra lobar BPS where you have pulmonary effusion, and especially a large pulmonary effusion. In those cases, it has been shown that laser coagulation of the feeding vessel is going to be helpful in reducing that mass size. So if you have a case like this where you have a mass sitting within the thorax with effusion, and this is the case where you can go in and try to laser out this particular vessel and thereby allow that mass to shrink. Coming to the last entity, that is chaos. Chaos is congenital high airway obstruction. It is not that common, but I have included it here because a lot of false diagnosis can come about for chaos, because when you see echogenic lungs, especially in the third trimester, you may think that you're dealing with chaos, but it is not, and chaos has got some really classical signs. So here you have obstruction of the upper airways. It could be the larynx or the trachea. Usually it's the larynx, and they are incompatible with life. So what you get is bilateral enlarged echogenic lungs, distal dilated airways, and you have a flattened inverted diaphragm. Actually, the dilated airways and the inverted diaphragm is the hallmark that creates the diagnosis of chaos. And if you look at this image, you can see that the heart is appearing to be small, and probably one of the conditions where you can have that a heart appearing to be small is this, because both the lungs are inflated and pushing the heart in the center. And you make your diagnosis clearly by looking at the trachea and see how the diaphragm is appearing inverted downwards. Now, as we go into the coronal sections, you can see that there is the inversion of the diaphragm and the trachea is clearly dilated. Now, having all that information in mind, now this is where virtual teaching is kind of difficult, because I usually have a case in the end, and I usually ask someone, do you solve this case? But I'm going to solve this for you and just take you through the steps that you would need while you're solving a case. So here you have a priming gravida, 23 weeks, right-sided thoracic mask. Now, when you have a right-sided thoracic mask, it could be anything. It could be a right-sided diaphragmatic hernia. You can see that there is a solid as well as a cystic component there. So it could be a hybrid lesion. It could be CPAM with BPS, and it could be a diaphragmatic hernia as well. So if you follow the steps, so if you have a mass like this, so what would you want to see first? You would want to see whether the liver is up or liver is down. So you would look at the umbilical vein. You would also look at the superior mesenteric artery, both of which look normal with no abnormal coursing upwards. And again, you would try to look at the diaphragm, and the diaphragm looks pretty much intact. So you would say that probably this is not a diaphragmatic hernia. And then you would go in and try to find out the vascularity or the vascular supply into that mass, and that is where you make your diagnosis. By looking at this, it is clear that you have the vascularity coming from the pulmonary side, both pulmonary artery and vein draining into this large mass. So you could say that probably this is a CPAM, and you already saw the descending aorta and the systemic vessels were not connected to this mass, and therefore your diagnosis would be that of a right-sided CPAM. And so it is actually a stepwise method by which you can actually solve the puzzle of any thoracic masses. And in fact, just to summarize it, all your diagnosis should be in a stepwise manner. And when you're dealing with CDH, it is important to rule out associated anomalies or aneuploidies, and you prognosticate CDH with observed or expected LHR. You prognosticate other lung masses with CVR. And it is very important to understand that the correct diagnosis would probably be the difference between life and death for that fetus. Thank you for listening. And I would also like to acknowledge all my consultants and fellows who helped me in sourcing these cases. So thank you for coming, and hope you liked the webinar as much as I did. Thank you very much.
Thank you everyone for participating in this session 5 of XP Connect webinar series. I would like to thank Dr. Bijoy Balakrishna again for making the session very informative and answering the questions. I am sure our viewers have much benefited from your expert clinical experience. Stay tuned to know the details for our next webinar. Please look out for a communication from GE team. Good night and goodbye.